Very good evening, everyone. So, we're meeting again after a while, and the target for today is, as you can see on my screen, I have 5 stars. So, basically, today's session, as I had communicated before, is a 5 star ophthalmology topics and MCQs. Well, I would like to say that I would be covering, when I say 5 star, this is for both NEET as well as FMGE, right? So by 5 star means they are must know. They are very, very important as far as both these exams are concerned. Right. So basically, this series that I'm taking on YouTube, it is a 1.5 hours session today and 1.5 hours session, which is on 26th. So that's again at 9:15. And basically, they here I will be taking one exam at a time. Like today, we'll be discussing the questions as well as the entire topic, the important things to remember. So that is what you call is learning in a retro mode. So I got a lot of requests that it is difficult for you to revise the topic once you're doing the questions. So I'll solve that query here, I'll solve that problem here. So we'll take up the question and we'll discuss that topic. So this way I will be taking each session one paper FMG, one paper NEET PG, and we'll have a pool of topics which have been asked in the previous 5 years, and we'll have a wider topic coverage. Right. So with that, if all is good, so that's basically the concept what I'm going to cover in the YouTube 5 star ophthalmology topics and MCQs. Right. If all is working good, if audio visual is working well, if you can just give me a thumbs up so that I can get started. So basically, before I start, I would like to tell you that ophthalmology special learning week is on 28th, right? Is on 28th. That's at 9 p.m. and that's a special learning week, which is a free special class. This is a free special class which will be on August 28th, 9 p.m. to 10 p.m. And what important topics will we be covering? We'll be covering about lasers and we'll be covering about retained intraocular foreign bodies. In that, I'll be covering two important things: siderosis bulbi and chalcosis. So this is in brief about the special learning week that is for targeting FMG December 2023, as well as these topics are equally important for NEET PG aspirants also. So this is what I want to bring into the notice, that for ophthalmology, the important date is August 28th, and the topics I have just told you, we'll be covering about lasers and retained intraocular foreign bodies. So as I said, this is important for both, again, for both, for NEET as well as FMG. So this is about the special learning week, which is the series of free classes available on the Unacademy app, right? And then also for the aspirants of FMG, we have target 150 plus in FMG for the ones who are targeting December 2023, right? So again, you have high yield practice questions covered in live sessions, you have revisions, test and discussions, and live doubt solving sessions. All the important topics and last minute tips and tricks to be discussed at subsidized prices. So you can use my code Bhumika for all additional benefits. Last but not the least, Unacademy is offering you 20% off, 20% off on all its subscriptions, 20% off on all Unacademy subscriptions. So that's a limited offer which is available till August 25. So August 25, do not forget, is where you can avail this offer. Again, you can use the code which is by my name, Bhumika. Last but not the least, we have iconic subscription. So when I talk of iconic subscription, what all do we include? We have Unacademy Plus, which is giving you live batches, which is giving you recorded content, which is giving you Question Bank 2.0 and PYQs live test and all quiz access with notes which are updated in Notes 2.0 and also the mentoring sessions. So with all these briefing, I will start with the 5-star ophthalmology topics and MCQs. So before I start, I told you the briefing is that we'll be taking one paper at a time and discussing the topic also. So today what we're discussing is this. We start with this question. So a patient presents with visual field deficit, which is characterized, and I will tell you how to attempt these questions. Once they are there, we all get panicky about left, right. We're already it's so much going on in our mind. Should always draw and write on the paper. So let's see. So when we talk about this question, it says a patient presents with visual field deficit, which is characterized by loss of left-sided vision in the left eye and left-sided vision in the right eye with macular sparing. So let's draw what are they trying to say. So if we have these two eyes, one is this and one is this. So this is right and this is left. So there is, what is the loss? It is left-sided vision loss in the left eye. So left eye, you have a left-sided vision loss. That means this has gone. And also left-sided vision loss in the right eye. In the right eye. But it says with macular sparing. So it's going to be, the loss is like this. Okay, what is this known as? So I would tell you one thing, visual field defects and visual pathway is something which you cannot miss at any cost. So that's the important take. One is visual field pathway. So I'll be writing down the topics also side by side, and visual field defects. That is the first 5-star that I'm telling you. Visual field pathway and visual field defects. So let's start revising first and then we'll see. So before we discuss about the defects, let's discuss what is the visual field pathway. So when we talk of visual field pathway, we all know that there are two eyes, right and left, and the visual field pathway starts itself from the retina. So what do you have? You have the retinal nerve fiber layers which get together at the blind spot at the optic nerve, and from here they continue as the optic nerve. So it is like this. Just look here. So here what you have is the retinal nerve fiber layers. You have the retinal nerve fibers layers which come together at the optic nerve head, and then it continues as the optic nerve. So what are the things that you should be able to identify? So here the retinal nerve fiber layers, they get together at the optic nerve head and they form this structure which is called as the optic nerve. So basically we go from eyes towards the brain. So the one which is away from the brain is actually distal, and the ones here is the proximal part of the optic nerve, right? So this part is called as the optic nerve, where all the fibers from the retinal nerve fiber come together to form the optic nerve, right? So always remember, answering a particular question is not important. You should be able to answer all the questions from that topic. That is where you have a win-win situation, right? So here we come down to the optic nerve. Then the optic nerve travels behind. It enters through the optic canal. It runs over the cavernous sinus and decussates. So once this decussation occurs, this is called as, what is this called? This is called as optic chiasm. But the important thing to remember here is that there is decussation of only nasal fibers. So important thing is it is an incomplete decussation. The temporal fibers, if you see carefully, so here you have two parts. One is the nasal part and one is the temporal part. One is the nasal part, one is the temporal part. So if you see carefully, it is the nasal fibers which are decussating. The temporal fibers, they pass uncrossed. So what is happening? The temporal fibers pass uncrossed. All right. So what decussates at optic chiasm? These are the nasal fibers which decussate at the optic chiasm. That is a very important thing. So here there is optic chiasm where there is decussation. The inferior fibers are placed anteriorly and the macular fibers are placed posteriorly. So that's another important thing. The inferior fibers are placed anteriorly in the chiasm and the macular fibers are placed posteriorly in the chiasm. So now from the chiasm, once they have crossed, so now they follow behind and this is called as the optic tract. So what does optic tract have? Optic tract consists of nasal fibers of the contralateral side plus ipsilateral temporal fibers. Is that clear? So if you see the left-sided optic tract, so for example, when we see a left-sided optic tract has right nasal fibers plus left temporal fibers. Let's see if that is a right statement. So left optic tract has right nasal fibers and left temporal fibers. Is that point clear to everyone? Is that okay? Give me a thumbs up and then I'll explain further. Is that okay? Give me a thumbs up if that is fine. Okay, so now when we are talking of this left optic tract, I said it has the temporal fibers of the left side. So temporal fibers of the left side are subserving to this field and right nasal fibers are again subserving to this field. So that means left optic tract is serving the right visual field. Now, is that point clear to everyone? If yes, then let me know. But if you want me to repeat, I will repeat. Just put it in the chat box. So this is the catch point everywhere. And this is a very important point, right? So whenever we talk of the optic tract, it has the contralateral nasal and ipsilateral temporal fibers because I told you temporal fibers go uncrossed. Therefore, the ipsilateral temporal and the contralateral nasal point out to the same side of the visual field. So optic tract and behind will always correspond to the contralateral visual field. Is that point clear? Okay, so the left optic tract when we are talking of has right nasal fibers and left temporal fibers which subserve the right visual field. Okay, so now then we move on to from here, from the optic tract, this passes behind and goes to this area which is called as lateral geniculate nucleus. But important point to remember here is few fibers they exit before it enters the lateral geniculate nucleus. So which fibers exit? The fibers which are responsible for the pupillary reaction. So the fibers which are responsible for pupillary reaction exit before they enter into the lateral geniculate nucleus. So that means all the lesions. So what does that mean? That means lesions which occur beyond optic tract will have sparing of pupillary reaction. Is that point clear now? Why? So why is pupillary reaction spared? Because before it enters the lateral geniculate nucleus, these fibers which are responsible for pupillary reaction, they exit the pathway. They go to the pretectum and they are responsible for the pupillary reflexes. Hence, whenever there's lesion which is beyond this point, will not affect the pupillary reaction. Is that point clear? All right. So then they go to the lateral geniculate nucleus. So we all know lateral geniculate nucleus is a mushroom-shaped structure. It has multiple layers which are 6 in number and has the terminations of magnocellular cells and the parvocellular cells. So there are P cells and there are M cells. So all these fibers, they terminate in the 6 layers of the lateral geniculate nucleus, which is mushroom shaped and has 6 layers. Okay. So from the lateral geniculate nucleus, the fibers, they curve around and they form the, what do you call it, as the optic radiation. They form what you call it as optic radiation. But the important thing to remember here is there is an important loop here. There is a loop here. So the inferior fibers, they form a loop here which is called as the Meier's loop. This is called as the Meier's loop. So this Meier's loop is present in the temporal lobe and it is formed of the inferior fibers of the optic radiation, right? So when we talk of Meier's loop, so what is Meier's loop? Meier's loop are the inferior fibers of optic radiation. They loop around to form the Meier's loop, and this is present in the temporal loop. Okay, so this is Meier's loop. So then you have the optic radiation which travels and it then terminates in the occipital cortex, striate area, Brodmann area number 17, or the striate cortex in the occipital area. So where do they terminate? They terminate in the striate cortex or what you call it as Brodmann area number 17, which is present in the occipital cortex. Is that point clear? Is that point clear? Everyone just give me a thumbs up if it is okay. So basically the tip of the occipital cortex or the occipital cortex is the area which has a dual blood supply, which has a dual blood supply. So even if the posterior cerebral artery is involved, even if the posterior cerebral artery is involved, there is macular sparing. And the macula is represented at the tip of the cortex, tip of the occipital cortex, right? So this entire pathway is very, very important. It is very simple, but it's just the mental pressure that we feel whenever we see this diagram. So let's quickly revise what we have learned, and then we'll go to the visual field effects. So basically what we just learned is we have the optic nerve coming up from here. When the retinal nerve fiber layers get together, they form the optic nerve. The nasal fibers, they decussate. The temporal fibers, they pass uncrossed, and here from the optic nerve they go to the optic chiasm. They cross the contralateral nasal and the ipsilateral temporal. They form the optic tract. From the optic tract they go to the lateral geniculate nucleus. From the lateral geniculate nucleus, these are the optic radiations which pass and they go to the striate cortex or Brodmann area number 17, which is present in the occipital cortex. The macula is represented at the tip of the cortex, and the occipital cortex has a dual blood supply. And here the optic radiation, here they loop the inferior fibers, they loop to form the Mears loop, which is present in the temporal lobe. Is that clear? So then we move on to the visual field defects. So now when we move on to the visual field defects, again they are very, very simple. So when we talk of the lesions at the optic nerve, so once the lesion is here at the optic nerve, which I label as 1. So when we talk of the lesion 1, what happens is we have two optic nerves. Let's say the lesion is in the right optic nerve. So whenever there's a complete lesion of the right optic nerve, there will be absolute scotoma, there will be absolute blindness of the involved side, but the other side would stay normal. Vis-a-vis affection of the pupillary reaction. So in the right eye, when I show the direct light, there will be no direct reflex, and the consensual of the right eye will also be absent. So that is when you deal with the pupillary reaction. Is that clear? So whenever there is affection of the optic nerve, there is lesion of the optic nerve, there is absolute scotoma, there is complete blindness on the involved side. So on the ipsilateral side, there will be absolute scotoma, there will be complete blindness, there will be loss of the direct light reflex as well as the consensual. Why? Because the nerve, the impulses are carrying through the optic nerve, the afferent has gone. Is that clear? So that is lesion 1. I am telling you visual field pathway and defects. This is one topic which I can write it down, guarantee you will have a question in every exam every time. So this is a must know, right? So this is lesion 1. Then we come to lesion 2. So when we talk of lesion 2 is this. So when we talk of lesion 2, so there are the two fibers which are decussating are the nasal fibers. So now here the lesion is through the bisecting the both the nasal fibers. So there will be loss of temporal field effects because both sided nasal fibers have gone. And this will result in the lesion of optic chiasm will result in bitemporal hemianopia. Bitemporal hemianopia. Bitemporal means both sides temporal field has gone. Why both side temporal field has gone? Because both side the nasal fibers are involved. Hemianopia, hemi means half, anopia means we are unable to see. So right, that is lesion 2, which is when there is the lesion at the optic chiasm, which is called as bitemporal hemianopia. Then we come to the third lesion, which is optic tract. So whenever there is lesion of the optic tract, so what is gone? Let's see. So whenever we talk of optic tract, I told you it subserves the contralateral visual field. So when you have a left-sided optic tract involvement, there will be contralateral visual field which is gone. That means right-sided visual field will be gone. So that results in right-sided homonymous hemianopia. By that I mean, I told you there is the contralateral field which it subserves to. Homonymous means it is similar in both the eyes. That means it is right on this, it is left on this and it is left on the right also. So both eyes have the same sided involvement. That means if it is the right side visual field loss, the right side of the right eye and the right side of the left eye is gone. Homonymous means similar, hemianopia. So that is when you have a optic tract lesion. All right. Similarly, all the lesions at the optic tract and beyond will result in the same lesion. That means the lesion of 4 will also be the same, except for the fact LGN and optic radiation, except for the fact there will be pupillary sparing. There will be pupillary sparing. So when we come to lesion 5, so lesion 5 I told you is the lesion of Meyers's lobe. Lesion in the temporal lobe, where which fibers are going? The inferior fibers are looping. Since this has the inferior fibers, so the superior field will go. Hence, it results in what kind of a field effect? What kind of a field effect? This is called as superior quadrantenopia. This is called as superior quadrantenopia. That is also called as pie in the sky. And where do you get it? You get it in the lesion of the temporal lobe. Is that point clear to everyone? Is that point? Yes. So there will be pupillary sparing. Why pupillary sparing? I told you because all the pupillary fibers have already exited before it entered the LGN. Right? So that is absolutely, you're right. There will be pupillary sparing. So that is superior quadrantenopia, that is pie in the sky appearance that occurs in the lesions of the temporal lobe. Next, we move on to the lesion of the optic radiation. So here were the inferior fibers, here were the inferior fibers, here are the superior fibers. So when you have the lesion number 6, so lesion number 6 is involvement of the parietal lobe. And that is, so when the superior fibers are involved, what kind of a defect we get? we get inferior quadrantenopia. You understand why now? You understand the position? Quadrantenopia means quadrant means 4. So one quadrant is involved and that is called as pie on the floor appearance. Pie on the floor appearance. Then we come to the lesions when there is complete involvement of the optic radiation. So when there is complete involvement of the optic radiation, it will result in the same lesion as we saw in the LGN, as we saw in the optic tract, which is a homonymous contralateral homonymous hemianopia. And there will be pupillary sparing. Okay, so that is important. So that is the lesion of the optic radiation. Then we come to whenever there is involvement of the posterior cerebral artery. Whenever the lesion is here, I told you occipital cortex has a dual blood supply. So whenever the lesion is in the occipital cortex or the involvement of or the occlusion of the posterior cerebral artery, there is occlusion of posterior cerebral artery. So then again it will result in contralateral homonymous hemianopia but with macular sparing. Why? Because macula is represented at the tip of the cortex. So here what we have is we have the lesions like this. So we have contralateral homonymous hemianopia with macular sparing. Okay, and whenever there is lesion at the tip of the cortex, so then when you have these lesions, so what do you tend to see here? You would have homonymous macular defects. All right, so that is when you have the tip of the cortex involved. Is that point clear to you? Now, important question which I want to ask you is, what is the difference between the lesions which are occurring in the optic radiation or between the lesions with that is 0.7 and involvement of the optic tract? So here we just learned when you have the lesion of the optic tract, number 3, you have homonymous hemianopia. Even when there is involvement of the optic radiation, 7 and 8, we have homonymous hemianopia. So are this homonymous hemianopia same? Is the homonymous hemianopia of optic tract same to the homonymous hemianopia of the optic radiation, or is there a difference? Anybody who wants to attempt on this one? This is a very important thing. So is it same or is it different? Just tell me, the homonymous hemianopia of optic tract, is it similar to the involvement or the homonymous hemianopia of the optic radiation or the posterior part? No, it is different because the more posterior it is congruous. It is congruous. So this is very important thing that you have to remember. This is more congruous. By congruous, we mean they are more symmetrical in both the eyes. They are more symmetrical. The defects are more symmetrical in both the eyes. That means the nearer to the brain the defect is, the lesion is, if it is nearer to the brain, if it is nearer to the cortex, it is more congruous. Is that point clear to everyone? So now we come back to the question from where we started. So you have a left-sided vision loss in the left eye, left-sided vision loss in the right eye with macular sparing. So what is this known as? Now you have to tell me what is the answer. The answer now becomes very clear. It is homonymous hemianopia with macular sparing. And where do you get to see this? We just learned we get to see this when we have the involvement of posterior cerebral artery. Is that clear? Now just give me a thumbs up if this visual, so this is, I told you this is, hence I have named this series 5-star because they are must know. Any doubts, just let me know. Otherwise, I'll move on to the next question. If all is okay, please give me a thumbs up so that I can move ahead. Right? So this is homonymous hemianopia with macular sparing, which is there when there's involvement of the posterior cerebral artery. Is that okay? So then we move ahead. Can I have a thumbs up if all is okay? Okay, so then we come to what is the most common primary intraocular tumor found in adults. So mostly in all my sessions, I normally conduct a series of most common. There's an entire class where we discuss the most commons because one-liners are there every time in every exam. So this is very, very important when we talk of most common. So here you have most common. The important word is primary intraocular tumor in adults. So tell me what is the answer. So it is the most common. Primary is one word. So whenever you attempt a question, you should know where to pay attention to. Most common, primary, intraocular and adult. So tell me what is the answer. Yes, the answer here is choroidal melanoma. But let's see what are the most commons that we need to know. So whenever we're talking of most common, as is asked here, so you know most common primary intraocular tumor in adults is choroidal melanoma. So most common primary intraocular tumor in children is yes, in children answer is retinoblastoma. Okay, so most common primary intraocular tumor in adults is choroidal melanoma and in children is retinoblastoma. Next, I asked you what is the most common benign tumor which is intraorbital in adults and in children. Tell me, what is the answer? Most common benign tumor which is intraorbital in adults and in children. What is the answer? Anybody who wants to try? So most common benign intraorbital tumor in adults is a cavernous hemangioma. And most common benign tumor in children is rhabdomyoma? No, it is capillary hemangioma. Right? So when we talk of hemangiomas, remember these are benign tumors. So now my next question is, what is the most common malignant malignant extraocular or intraorbital. Intraorbital, or you can call it as extraocular tumor. Again, it has to be divided into adults and children. Now, here is what you're trying to answer is most common malignant extraocular or intraorbital, that means within the orbit, but it is outside the globe, in children is rhabdomyosarcoma. And in adults is non-Hodgkin's lymphoma. Is this slide clear? So this is a very, very important thing. Most common primary intraocular tumor in adults is choroidal melanoma. In children, it is retinoblastoma. Benign intraorbital or extraocular is always hemangiomas. In adults, it is cavernous. In children, it is capillary. Malignant intraorbital or extraocular in adults is the non-Hodgkin's lymphoma, and in children is rhabdomyosarcoma. Another thing I want to ask you, if I omit the word primary here, just in case I cut the word primary, the most common intraocular tumor in adults is, now the answer would be different. Primary means something which is originating inside the eye. So, but the most common intraocular tumor in adults are the secondaries. Is that point clear? So it is the secondaries. So this is in main what you should be able to see. So now what you see on the screen is, can you tell me what image is being seen here? Which tumor is this? It is the most common primary intraocular malignancy of adults. So with what is this? What do you see on your screen? What do you see on the screen? So it is of two types. It is either pedunculated or it is flat. So what am I? What am I? I am choroidal melanoma, or what you better call as malignant melanoma of choroid, or of, I would call it as of uvea, which can be at the level of the ciliary body or choroid. So it is of two types. It can be pedunculated, which is as is shown here. It can be pedunculated. Once it is pedunculated, it is called as collar stud tumor, or it can have an appearance like a flat lesion. So collar stud tumor is the pedunculated tumor, or it is a mushroom shaped tumor like this, which arises from the choroid. Right? So this is the choroidal melanoma. Very important thing that you normally get is, what is the histopathology? What is the histopathology of choroidal melanomas? So whenever we talk of histopathology of choroidal melanomas, please remember it is of four types. It is of four important types. They are the ones which you see here predominantly when you have more than 90% as these spindle shaped cells. So this is called as spindle cell melanoma. Right? The spindle cell melanoma, once it can have a spindle A-type cells or spindle B-type cells. And when more than 90% of the histopathology has these spindle cells, these are called as spindle cell melanoma. The other type is this one which you see here, when you have these pleomorphic cells. So here what you have is pleomorphic cells with large nuclei. So what you have these pleomorphic cells with large nuclei and abundant acidophilic cytoplasm. And when such cells are more than 90%, these are called as epithelioid cell melanoma. Okay, when you have the mixture of the two, it is called as mixed cell melanoma. And last but not the least are the necrotic cell melanoma. When you have predominantly more of undifferentiated cells. So we have 4 histopathological types. We have spindle cell melanoma, we have epithelioid cell melanoma, we have mixed cell melanoma, and we have necrotic cell melanoma. So my next question, which is very commonly asked, is which out of the 4 histopathological types has the best prognosis? Now tell me, which out of these 4 has the best prognosis? Tell me, which one has the best prognosis? So which histopathological finding or type of histopathology has the best prognosis? So remember, it is the spindle cell melanoma which has the best prognosis, and it is the epithelioid cell melanoma which has the worst prognosis. So this is important as far as these histopathological findings are concerned. So you should know which histopathology has the best prognosis and which has the worst prognosis. So these are the histopathological findings of choroidal melanoma. Then we move on to these. So what are these? So this is the histopathology of retinoblastoma. Also called as small blue cell tumor. So now if I show you these slides, you have to name which one are these. What is this called as? This is the pattern A and this is the pattern B. What is A called as? So when you see here, you have the viable tumor cells around a blood vessel. So what do you get to see here? There is a blood vessel. So when you have all these viable tumor cells around the blood vessel, which is present here, which is present here. So here you call it as pseudo rosette. So what do you call it? You call it as pseudo rosette. The second appearance that you have is this. When you have these cells which are surrounding a central lumen. So L shows you a lumen which is lined by refractile membranous structures, which is lined by, so you have a lumen and it is lined by, so you have a lumen and it is lined by refractile membranous structures. This is which appearance is this? This is called as the Flexner winter Steiner rosette. Flexner winter Steiner rosette. Then we come to this appearance, which is C and D. So what is C? So when you see image C, what do you get to see? You tend to notice that the cluster of cells which are arranged like a bouquet of flowers. So you have the cluster of cells, curvilinear cells, which are placed like a bouquet of flowers, and that is called as this is called as florets. So that florets means like a bouquet of flowers. And then you have D, where there is no lumen. So when we talk of D, there is no lumen, and it has all these neurofibrillary tangles in the center, and it has neurofibrillary tangles in the center. So you see here, there are neurofibrillary tangles in the center. So this is called as the Homer Wright rosette. So now my next question is, which out of these four findings is the most specific of retinoblastoma? So which out of these four findings is most specific of retinoblastoma? The answer is this one. So this is the most specific of retinoblastoma. The other findings that you can have is, the here star, you can have necrosis, and the purple area you can have calcification. So you should be able to answer this now. What are the histopathological findings of retinoblastoma? Most specific of retinoblastoma, the histopathological findings of malignant melanoma of choroid, which one has the worst prognosis and which one has the best prognosis. Then we move on to the next one. A patient who works in an iron industry. Presents with iron deposits in the eye along with visual field defects. Which of the following condition is the most likely responsible for this ocular finding? So tell me, what is the answer? Is it retinitis pigmentosa? Is it siderosis bulbi? Is it chalcosis? Or is it KF ring? What is the answer? What is the answer? Okay, so basically, when you have to discuss about things like this, so here when it talks about iron industry with iron deposits, that means it is talking of something about the retained intraocular foreign bodies. And as I just told you, the answer to this you will get in the free special class, which is at 9 p.m. on August 28, 9 p.m. on the Unacademy app, where we will discuss about whether it was what we are talking about is siderosis bulbi or what we're talking about is chalcosis. So this is the free special class lasting, that is for, the duration is for 1 hour, covering where I would be covering the retained intraocular foreign bodies and the laser. Right? So we'll discuss this question that day. And now we come to suturing in cataract surgery is commonly performed in which type? So basically here the question is asking you about various types of cataract surgeries that you should know. The options are phacoemulsification, ECC, flax, or micro small incision or manual small incision cataract surgery. So whenever we talk of cataract surgery, let's see how it evaluated. So important things about cataract surgery is you should know what are the types of cataract surgeries, what are the incisions that are given, and how do we do that. So these are important things. So whenever we talk of the cataract surgery, it is divided into intracapsular cataract extraction and extracapsular cataract extraction. So when we talk of an intracapsular, intra means with the bag, with the capsule. So here you have the lens and the nucleus and the cortex inside, and then you have the epithelium, or you have the bag which is present. So once you take out the entire capsule and its contents, that is called as intracapsular. So this is the intracapsular cataract surgery, when you take out the contents plus the capsule. Right? So you take out the entire thing. The other is the extracapsular cataract surgery. So when we talk of the extracapsular cataract surgery, here you just take out the contents of the bag. You just empty the contents of the capsule and you leave behind the capsule to place the IOL over it, right? So the extracapsular cataract surgery is further divided into the conventional extracapsular cataract extraction, small incision cataract surgery, and phacoemulsification. The further advances that we have after phacoemulsification is micro-incision cataract surgery and FLACS. What is FLACS? FLACS is the femtosecond laser assisted cataract surgery. Okay, so these are the advancements from phacoemulsification to microincision to FLACS, right? So now another important thing is what are the incisions that are given here. So an important and easy way to remember is, as I said, just remember one measurement of SICS. So what is SICS? SICS means around 6 millimeter. 6. SICS is 6. So just remember the figure SICS. That is around 6 millimeter is the incision. So from SICS, if we go into the intracapsular, if you go into the intracapsular times, which is the initial ones, just double it. Just double it. So if you double this, so this is around 10 to 12 millimeters. Okay. From 6, the older one is conventional ECC. So it should have a bigger incision. So add 3. So this is around 9 millimeter. 8 to 10 millimeter is the incision. After SICS, we have phacoemulsification, which is a better form. So the incision would be smaller. So you minus 3. So the incision size would be somewhere around 2.8 to 3.2, and average being 3 millimeter. That is for phacoemulsification. Then we come to the smaller further. From phacoemulsification, the further advancement is the micro-incision cataract surgery. So when we come to the micro-incision, it has to be smaller than 3. So it is less than 2 millimeter incision. And last but not the least, we have femtosecond laser. So with the lasers, you need further lower incisions, and that is to the tune of 0.9 to 1.8 millimeter. That is roughly around 1 millimeter. So this is how you remember the sizes of the incisions and the name of the surgeries, right? So that is an easy way to remember this. Then when we talk of how and when, that is one, and where do you put sutures? So SICS, small incision cataract surgery, has a self-sealing wound. This has a self-sealing self-sealing wound. So obviously the ones which are older than this has to be given the sutures. So older than this, we have two surgeries, which is intracapsular cataract extraction and the conventional ECC. So when we come back to the question, now let's try and attempt it. So now you tell me what is the answer. Suturing in cataract surgery is commonly performed. Is it phacoemulsification? No. Is it extracapsular cataract surgery? The answer is yes. Is it flex? It is no, because it is advanced. Is it manual small incision cataract surgery? No. So this is the answer. Extracapsular cataract extraction is where you put in sutures, and now you should know how to identify. So here if you see two images, these are two images, that is A and B. So now you have to tell me what is image A and what is image B. Both these images have sutures on the cornea. So how do you identify which of these two is ECC, and if the other one is not ECC, what is it? So tell me. So when we see it image A, so what you see here is you see an incision here where these sutures have been put. So this is the older surgeries that we are talking about. It can be an ICCE or it can be the conventional extracapsular cataract extraction. But since we can see the sutures placed here on the incision site, so it has to be either of the two. If the bag was also taken out, that was intracapsular. If the bag was left behind, it is extracapsular. But if that is the, so this one is for the cataract surgery. So if that is cataract surgery, what is image B? So when you see the image B, what are you noticing? There are sutures which are present all around in a uniform radial manner. So what sutures are this, and which surgery has been done here? This is for keratoplasty. And what is keratoplasty? That is the corneal transplant. That is the corneal transplant. So here the entire cornea has been replaced with the donor cornea, and that is called as keratoplasty or the penetrating keratoplasty. So here how will you identify? You will identify by the fact that there are sutures in the radial manner 360 degree, right? All around there are uniformly placed sutures. So now you know how to differentiate whether the cataract surgery has been done or it's a keratoplasty, right? Then you come to, now you tell me which surgery is this. So if you have to identify which cataract surgery is this. So this is the surgery where I told you it has a self-sealing wound. So this is the surgery which has a self-sealing wound, and there will be a tunnel. So what do you get to see here? See here, there is a tunnel. So there is a self-sealing wound and it has a sclerocorneal tunnel. So which surgery am I talking about? I am talking about SICS, which is the small incision cataract surgery. So this is how you identify the images. So here also, if you see, if you have a post-op image given in the question that identify which surgery was done, so you will see superiorly there is an incision which is given there, right? So that is a sclerocorneal tunnel which was formed by a self-sealing wound. If that is in the question is talking about SICS surgery. Then we come to this image. So now tell me which cataract surgery is being done here, and it is being done using this instrument which is called as the phaco probe. So which cataract surgery is being done here? Anybody who wants to attempt? Which cataract surgery is being done here? So when you're using a phaco probe, so what you are trying to do is You are doing a phacoemulsification. So if in anywhere in the image you see a probe like this, which has been taken inside through a corneal wound and is trying to emulsify the nucleus, that is when which surgery is being talked about. It is talking about phacoemulsification. All right. Okay. Then we move on to the next one. So now it says Fletcher ring is the deposition of. What is Fletcher ring? Tell me. Fletcher ring is the deposition of. Fletcher ring is the deposition of. Is it iron? Is it copper? Is it zinc? Or is it molybdenum? What is it? So Ayaj Sheikh says it is A. It is iron. So when I talk of Fletcher ring, can you tell me which disease are we talking about? Which disease are we talking about? When I talk of Fletcher ring, which disease are we talking about? Okay, Hiran also says A. So, but now you tell me which disease do you find Fletcher ring? The hint is here. So, if you see the cornea carefully, you have an ectatic condition of the cornea where it is shaped like this. So, I have taken a hint here also. So which condition are we talking about? So Fletcher ring or is seen in this ectatic condition where you see a cone shaped cornea. You have a cone shaped cornea. So what is it called? Anybody who wants to attempt? What is it called? It is called as keratoconus. It is called as keratoconus. What is keratoconus? I told you it is an ectatic condition of the cornea. It is a bilateral condition. It is non-inflammatory and it is progressive. So where you have a conical shaped cornea, a cone shaped cornea, an important point to remember here is that this cone is not present in the center. It is not present in the center, but it is slightly inferior to the center. So here this is the apex of the cone which is present inferior to the center. So this is keratoconus. Kerato means cornea, conus means cone shape. Which is the other ectatic condition that we know of? So one is keratoconus and the other is keratoglobus. So which out of the two is developed later? Keratoglobus is present since birth, but keratoconus is something which you develop around puberty. So this is keratoconus. So what all defects do you get to see? So can anyone just tell me which investigation is shown here? Which investigation is shown here? What is this investigation that is shown here? Where you get to see irregular Myers. Here what do you get to see? You get to see irregular Myers in keratoconus. So which investigation is this? Tell me. Which investigation is this? So this is the Placido disc. This is the Placido disc examination. So what you get to see, if you see carefully, the Myers are irregular Myers. So the irregular Myers are seen in Placido disc examination on keratoconus. So what are the important signs of keratoconus is what is an important question. So again, I tell you, so this is a very important topic, that is keratoconus. Very, very important. Again, you get to see almost every time in an exam. So what are the signs of keratoconus? Again, important. So when we talk of the signs of keratoconus, please remember the earliest sign. Which is the earliest sign? It is not shown here. It is the scissoring or yawning of red reflex. So this is the earliest sign of keratoconus. So what are the other signs that you get to see? So if you see carefully, see the image A. So let's talk about one by one. So this is A and B and C. So when we talk of image A, so what do you see? You see a small dark color circle in the here in the cornea. When you see it in the distant direct ophthalmoscopy, what you get to see? You get to see a darker reflex. So this is called as the oil droplet reflex. This is called as the oil droplet reflex, or which is popularly called as the Charley's sign. So the dark reflex which comes on distant direct ophthalmoscopy, that is from the base of the cone, is called as the oil droplet reflex. The other sign that we see is when you throw the torchlight on the temporal side. On the temporal side, the nasal side of at the limbus, it gets illuminated in an arrowhead manner. In the arrowhead manner, and this is called as the Rizzuti sign. This is called as the Rizzuti sign. The third important sign that we have is, if you see carefully, there is a circular structure like this which is marked by the white arrow. This is called as the Fletcher ring, and this Fletcher ring is because of the deposition of iron at the base of the cone, at the level of the basal epithelium. Right? So this is exactly what has been asked in the question. So Fletcher ring is the deposition of. Now you tell me what is the answer? The answer is iron. So what do we need to learn here? We need to learn about keratoconus. So we know what is keratoconus and what are these signs. We know what is oil droplet reflex or Charley's sign, Rizzuti sign, Fletcher ring, and others are. This is D, E, F. So this is D, E and F and G, the other signs. So what is this sign? This is called as the Munson's sign. This is called as the Munson's sign. So what sign is this? This is called as the Munson's sign. There is, once you try to look down, there is the lower lid gets pointed out. There is disfiguration of the lower lid margin on looking on the down gaze, right? So there's a deviation in the lower lid margin contour which you can see here, which is because of the conical shape of the or the ectatic cornea. Then you have the ruptures in the Descemet's membrane. Why? Because the cornea is stretching, it is becoming conical. Ultimately what happens, there are ruptures in the Descemet's membrane and the entire cornea becomes opaque. It is edematous. This is called as acute hydrops. Also important, if you see here carefully, what do you get to see? You get to see these fine lines. So which the fine lines which get obliterated on the external pressure. That means these are the fine lines in stroma, but they disappear on external pressure. And what do you call them? What are these called? These are called as Wort's stria. These are called as Wort's stria. And last but not the least, what you have is, you have enlarged cornea. right? So these are the important signs of keratoconus. A must know. Keratoconus must know. Visual pathway defects and visual pathway must know. These are the topics where you can't afford to sit without knowing them. Okay, so this is keratoconus. So now what I had a question, Bibek Raj Parajali answered Wilson's disease. So what does Wilson's disease has? What I had known here. See, I already knew that would be the point of confusion. So I always say it is always better to make mistakes here when we are discussing rather than to make mistakes on the D-Day. So now you have to tell me what do you get to see here when you talk about Wilson's disease? If you see this image carefully, this image is from Wilson's disease, from a patient of Wilson's disease. So tell me, what do you get to see here? Which is a very common point of confusion. So this is the patient of Wilson's disease, also called as hepatolenticular degeneration. So what is the corneal sign that we get in Wilson's disease? Absolutely, Ayad Sheikh. It is because of the deposition of copper. There is deposition of copper at the level of Descemet's membrane. And what is it called? Now, this is called as the KF ring, or it is called as the Kayser-Fletcher ring. So now there's a difference. This is KF ring, Kayser-Fletcher ring. But here in keratoconus, it is just the Fletcher ring. So the Fletcher ring is because of the deposition of iron at the base of the cone in the basal epithelium. Whereas when we talk of the Wilson's disease, what we are talking about is the copper deposition at the Descemet's membrane of the cornea. And where do you get to see it? You get to see in Wilson's disease. So that is the Kayser-Fletcher ring. So is that clear? Now, no confusion between the two things. Is that clear? So this is the Kayser-Fletcher ring, right? So it starts normally superiorly or inferiorly, and then it slowly engulfs the entire cornea. Hepatolenticular degeneration or Wilson's disease. Which second other finding do you normally get to see in the patients of Wilson's disease along with KF ring? Which other finding do you get to see? We get to see sunflower cataract. So whenever the question is talking about sunflower cataract along with KF ring, just think of the Wilson's disease. Okay. Then we come to this question. Then we come to a patient with history of eye trauma with vegetative matter. So vegetative matter, the causative agent under microscope is seen as septate hyphae at an acute angle. So this was the question in this year, just now July FMGE exam. So whenever we're talking about this question, what I'm highlighting here is keratitis. Must know. I told you 5-star ophthalmology. 5-star ophthalmology. Be it fungal, be it bacterial, be it acanthamoeba, be it viral, it will be there in one form or the other. Right? So whenever it talks of vegetative matter, there are very clear-cut answers to this. Whenever the question talks of vegetative matter or the question talks of animal tail or the question talks of farmer, always the answer would be farmer, animal tail, vegetative matter. The answer would be fungal corneal ulcer. The answer would be fungal corneal ulcer. When we talk of bacterial corneal ulcers, viral corneal ulcers, and acanthamoeba, whenever the question talks about contact lens use, It is talking about acanthamoeba. Or it is talking about, so the most common infection in contact lens users is of Pseudomonas aeruginosa, right? So, but contact lens use, acanthamoeba is very specific for contact lens use. Viral corneal ulcer will mostly come in these patients who are having some stress situation, some anxiety when the generalized immunity is being depressed. So let's talk. So I told you, anytime the question talks about trauma with plant with vegetable matter by animal tail is always fungal keratitis. That is, which occupation is more exposed to this? The farmers. The farmers are more exposed to this. Then you might have it when the patients have topical corticosteroid use, immunocompromised patients, chronic keratitis and corneal surgeries. So whenever the question talks about a very specific thing, I told you it is fungal keratitis. So what are the most common organisms which are involved in fungal keratitis? It's again a very important question. 1, 2 and 3. One is Aspergillus fumigatus. Number 2 is Candida. And number 3 is Fusarium. So the most common organisms which result in fungal keratitis, you should be able to name these 3. The first is Aspergillus, Candida and Fusarium. So most common fungi, most common organisms responsible for fungal keratitis, right? So how do these fungal keratitis looks like? How do you know it is fungal keratitis? Always remember, they have fewer signs and symptoms and pain is out of proportion to what you see. Very important. Whenever the question is talking about a predominant feature of pain, but fewer signs and symptoms. More so, specific things to know about fungal keratitis is they are dry looking ulcers with ill-defined margins, they have feathery margins, multiple lesions, which is called as the satellite lesions. They have Wesley ring, which is the ring because of the antigen antibody reaction. It is a immune ring. It is a sterile immune ring which is present, right? So these, and you will have a hypopion. And remember, the hypopion of fungal keratitis is fixed and it is non-sterile. It is non-sterile. So these are the important things of fungal keratitis. So when you look at the image, it is a dry looking ulcer which has irregular margins, which has feathery margins. It has more than one lesion which are called as the satellite lesion, and it will have a hypopion. This hypopion is fixed. It does not move when you tilt your head, and it is non-sterile. Why? Because fungus can actually penetrate the intact cornea. Then how do you differentiate between image A and B? So what is A and what is B? Anybody who wants to say what is A? So which out of these two is the fungal corneal ulcer? Tell me, is it A or is it B? So I just told you, a dry looking, ill-defined, feathery margins, multiple lesions is fungal keratitis. So when we talk of bacterial, it would be a single infiltrate. It will be a single infiltrate which is well demarcated, has associated edema, there will be suppuration, and there will be hypopion. But please remember, the hypopion of bacterial corneal ulcer is mobile and it is sterile. It is mobile and it is sterile. Because it is not because of the invasion of the organisms, but because of the toxins. So do you get that difference? So fungus, you have a fixed hypopion and it is non-sterile. Whereas the bacterial corneal hypopion would be mobile and sterile. Okay, so you have a single infiltrate where there is suppuration. So here if you see, there is a single infiltrate, there is suppuration, there is pus. It is well demarcated, it has associated edema which is present, and it has a hypopion. So this is the, what is this? So this is the bacterial corneal ulcer. Is that clear? So this is how do you differentiate between the fungal and the bacterial. Then we come to what is this which is shown. So the image like this, when you have identify this lesion, which lesion is this? So this is the dendrite. This is the dendrite. What is a dendritic ulcer? Dendritic ulcer are the ulcers which are in an arborizing pattern. So what you have? The ulcers where you have an arborizing pattern with terminal bulbs is what you call as a dendrite. Whereas if you see this lesion, there are no terminal bulbs. There are no terminal bulbs. So what do you call them? You call them as pseudodendrite. So now the question is, where do you get to see dendrite? So these are actually seen in cases of viral keratitis. Okay, so when we are talking of dendritic ulcers, so viral keratitis, we have two important organisms, herpes simplex and herpes zoster. So when we are talking about herpes simplex, whenever we are talking about dendritic ulcer, we are talking about herpes simplex. And whenever we are talking about pseudodendrites, the dendritiform lesions where there are no terminal bulbs, the pseudodendrites, we are talking of herpes zoster virus. That is shingles. Or it is called as herpes zoster ophthalmicus. So that is viral keratitis. So you get to know the difference. So this is viral keratitis, which is herpes simplex virus or herpes zoster. So you had fungal, you had bacterial, you had viral keratitis. And another important thing in viral keratitis is there will be reduced corneal sensations. So dendrites, herpes simplex virus, pseudodendrites, herpes zoster. Then you might have lesions where you think of acanthamoeba. So whenever we talk of acanthamoeba I told you will have contact lens use, pseudomonas or aeruginosa, which is also seen in contact lens use. Acanthamoebas, the specific thing is they have ring infiltrates. They have ring infiltrates. That's very important for acanthamoeba corneal ulcer, right? So that is how you identify fungal, bacterial, viral, and acanthamoeba. All right, then we move on to the next one. What dye is used for anterior chamber of the eye? Now, this is very, very important. Now, you all know when we talk of anterior chamber, we're talking of intraocular structures. Intraocular is an anterior segment and a posterior segment. Anterior segment will have anterior chamber and posterior chamber, which has aqueous. So, when we are talking about which dye is used in the anterior chamber of the eye, this is very important. Can you tell me which dye is used? Is it trypan blue? Is it brilliant blue? Is it fluorescein, or is it lissamine green? So dyes are an again important thing. So basically vital stains or dyes in ophthalmology is an important topic in itself. Okay, so now let's quickly see. When we talk of trypan blue is something which is used in the concentration of 0.06%, and the basic use of trypan blue is to stain the capsule. So it is a capsular dye. One thing, so that is trypan blue. Then we have brilliant blue. So when we talk of brilliant blue, it is actually BBG. So when we talk of BBG, it is brilliant blue G dye. And the classical use of BBG is done in cases of macular hole surgery. And this is used to stain internal limiting membrane. So this is used for internal limiting membrane staining. The third important thing that has come up is fluorescein dye. The fluorescein dye has a beautiful mnemonic OBG. It is an orange colored dye which is irradiated with blue color and emits green color. So when we talk of fluorescein is very important because fluorescein dye is something which is very commonly, or I would say most commonly used dye in ophthalmology. So let's see, where do we use them? So fluorescein dye is used to have a dry eye evaluation, in which you will see for TBUT, tear film breakup time, to assess tear meniscus and dye disappearance test. Fluorescein is also used in applanation tonometry. Fluorescein is also used in Jones test. Fluorescein is also used in canalicular injuries to identify canalicular ends. And fluorescein is also used in FFA, fundus fluorescein angiography. So it has so much of usage in ophthalmology. So this is the fluorescein dye. And then you have lissamine green. Lissamine green is a food additive. So lissamine green So when we talk of lissamine green, please remember it is a food additive. And it is basically used to stain conjunctiva. So the question, we come back to the question, which dye is used for anterior chamber of the eye? I'm not saying intraocular. So anterior chamber would have the capsular dye. And hence the answer here is trypan blue, which is used in cataract surgeries to stain the capsule. Right? So these are the dyes that you must know and are important. Right? So I will end up the session here today. That is it for today. We'll continue this further into the second one, which is on the session that is scheduled for 26th, right? So, all right. So till then, take a break, sleep well and study well. You can keep revising. I'm telling you, the way we are discussing, you would not need to go back and open your books. You know the question, so we're revising the question and we're revising the topic. So once again, I'll take you back to the free special session that we have. As I told you, the free special class that we have on 28th at 9 p.m. on lasers and retained intraocular foreign body. That's a very, very important topic, especially lasers. So I would want you all to enroll to this session. It is a free special class, but enrollment is mandatory. So we meet on 28th at 9 p.m. But before that, we have one more 1.5 hour session, which we meet again at 9:15 day after tomorrow. Right? Till then, have a good sleep, study well, keep working hard, because there is no shortcut to success. You need to have a basic knowledge. When you sit in the exam, only reflexes work. You are so stressed, so anxious, that you need to build in the reflexes by revising again and again. So need not worry, December still has time, but these are the important topics for NEET as well as FMG. So till then, I'll take a break. I'll sign out. Have a good sleep. Good night.